I welcome the opportunity to speak in this debate and congratulate Emma Roddick on securing it. Having just heard Ms Roddick, what she's described, I value her knowledge and input this evening. I do recognise the concerns that Emma Roddick has highlighted both in her motion and what I found regarding misinformation, extreme nonsense, fake news, bad actors seeking to exploit the use of AI to damage reputations, to exploit people and harass victims, especially in relation to violence against women and girls. So we know this must be addressed where we can by regulation and by legislation. It must not be a surprise to colleagues across chamber, though, that I'm going to speak about AI and its potential in healthcare this evening. I worked in a tech-driven perioperative environment as a registered nurse. We have heard artificial intelligence. It's a broad term. It spans everything from simple decision trees akin to flowcharts to complex large language models and generative AI, an example of which would be ChatGPT. The risks posed by each type of AI are different, and it is important that we should be careful not to unintentionally tar all AI models with the same brush. The risks with simpler AI and even machine learning are low by comparison to those associated with deep learning, again used by platforms such as ChatGPT. It is important to note that we've been using AI safely in healthcare since 2010. We introduced AI to replace the second clinician in our double-reader national diabetic retinopathy screening service. And we also use AI in dynamic radiotherapy treatment, paediatric cardiology, paediatric growth measurement, and in radiology medical image acquisition, including in CT scans. It is therefore important that we carefully consider the risks of not implementing AI, as well as the risks and benefits of implementation. This is a balance, and we must remain cognizant that over-caution could lead to slower progress in, for example, positive healthcare outcomes. For example, recent evidence from trials of AI to prioritise cases of suspected lung cancer in Scotland indicate around 600 more people each year might survive the disease because of introducing AI alongside other measures to optimise the pathway. So creating a balance and recognising the distinction between different types of AI are so important, and I would ask the Minister to keep this in mind in relation to developing AI policy. Presiding Officer, the performance and risk of AI are highly localised to the context in which it is used and deployed. Not only is it impossible to remove all risk in advance of implementation, but it is essential that we must proceed to implement AI. The only way to mitigate and manage risk is to understand the risks, and I would suggest that should be done in healthcare through controlled AI. My recent engagement with a healthcare AI expert made the point that in healthcare the focus is and must continue to be on humans plus AI, not humans versus AI. Presiding Officer, turning to the legislation and the regulation of the use of AI and addressing the point that Emma Roddick has made regarding the dangers of AI, legislation, regulation and policy, it all must help to make AI safer. So it's especially important when focused on the standards necessary for implementing of AI into public service. For example, the medical device regulations already govern the use of AI in relation to investigation, diagnosis, treatment, prevention, monitoring, prediction, prognosis or alleviation of disease, injury or disability. So I'm conscious of the time, Presiding Officer, and you did tell me up to 4 minutes. So again, I recognise and agree with what Emma Roddick has described very effectively, and I wanted to highlight how we can and should propose and progress AI, but we need to manage and mitigate any dangers and risks there. Thank you.